Well, the PROWL studies were really a reaction to the FDA had 140 letters written to it in 2008 from patients who were dissatisfied with their LASIK. And out of those 140 patients, probably about 25% of them complained about symptoms related to astigmatism in their comments. So together, the FDA, the American Academy of Ophthalmology, and the ESCRS put together two studies, PROWL-1 standing for patient-reported outcomes with LASIK. PROWL-1 was with military personnel, and the second one was with general population people who are having LASIK treatment for astigmatism associated with myopia. And what they found, which was a surprise, in that in the first study 43%, and the second study 46% of patients found they suffered from glare and starburst and halos after the surgery, which are symptoms they hadn't actually suffered before the surgery with contact lenses or spectacles. And this was really a surprise to the patients and also to the doctors. The unfortunate thing about the study was it didn't really go into these problems in much detail, because they didn't really examine in any detail the amount of corneal astigmatism that was remaining on the cornea. They did talk about refractive outcomes, but not corneal astigmatism outcomes. And so this is where we find that the important component of it is we found that the result of all these symptoms of glare, halos and starburst, commonly called GASH as an acronym, is as a result of too much astigmatism being left behind, principally on the cornea, but also in the refractive cylinder remaining in the patient in a spectacle correction. Well, this is a very interesting question, because the incidence in these patients was of the order of 43% in the first study and 46% in the second study, which is pretty consistent for two studies, both of which had about 300 eyes in each of the studies. Because one of the things that we've noticed in a study by Dr. Frings from Hamburg was that 46% of patients had an ORA, which is a vectorial calculation measure of the difference between corneal and refractive parameters. 46% of patients actually had more than one diopter or more of ORA. So when you treat totally by refraction, like manifest refractive spectacles, all this ORA is neutralized on the cornea as corneal astigmatism. So therefore you would expect more than one diopter of corneal astigmatism left remaining. And we believe that this excess corneal astigmatism remaining results in excess astigmatism in the refraction. But with vector planning, you're able to reduce this by making the treatment a combination of topographic as well as refractive parameters, not just refraction alone. And so by having the treatment somewhere closer to the corneal parameters, you end up with consequently less vision, less astigmatism on the cornea, and a better visual outcomes as a result. And this has been shown in about 4 studies now of the improved visual outcomes with vector planning. Well, what causes it is the excess astigmatism on the cornea. The patient may see very well, they may get 20/20 or 6/6 vision, but they're unhappy because when they drive at night, you can see clearly when there's low ambient light and you can see details. But as soon as any bright light hits your eyes, you almost are blinded by it. And this is why many patients, whether they've had laser surgery or not, are very fearful of driving at night, because if they suffer from glare and halos, it's very disabling, because their ability to see in low light conditions is diminished significantly to the point where they don't feel comfortable driving a car. So in patients who never suffered from this, wearing glasses or contact lenses, and all of a sudden they've had surgery and suffering from these symptoms, it's a surprise because they haven't had it before. And even in the PROWL studies, in both of them, they recognised and classified it as surprising symptoms, because it surprised both the patients and the doctors who are conducting the study. And that's a very good question, because vector planning that I mentioned, where you take corneal and refractive values in the treatment plan, reduces corneal astigmatism by 40%, and also refractive cylinder is also reduced. What we've done is we've put up at the ESCRS.org website, of the Journal of Refractive Surgery website, a calculator, both for calculating ORA, because the ORA, if it's more than one, like I mentioned, you can predict this is going to happen, because they're going to have more than one diopter of corneal astigmatism remaining and the symptoms can occur. And the ORA calculator, together with the vector planning calculator, which we provided at the ISRS website for free to members, you can do the calculation when you find the patient does have an ORA more than one, then they can do vector planning, and that will minimize the amount of astigmatism remaining. So if it had been 1 1/4 diopters was going to remain because of an ORA of say 1 1/4, instead of that it's only going to be 3/4. So you've reduced it by 40%, and in that way 3/4 of a diopter astigmatism are within normal bounds and limits that patients can cope with and don't suffer these kind of symptoms to anything like that kind of extent of 46%. Well, first of all, vector planning is useful for patients who have astigmatism. So if you're just doing a spherical PRK or LASIK, vector planning doesn't have a place. It has a place in patients who have astigmatism correction. Personally, I use it for all patients because we just use it as a routine. If you wanted to be selective, you definitely use it for any patient who has an ORA of more than 0.75 as a routine. Because these people, instead of having 0.75 or more cylinder left on the cornea, it's only going to be about 0.45, and that's very manageable. So everybody who has vector planning has less astigmatism remaining on the cornea, and then they'll have less astigmatism in the refraction as a result. So it really should be used as part of a routine treatment in any astigmatic treatment.